go ahead.
Hello,
Yeah,
just a second.
yeah.
It is
If you click on it, yeah.
okay. Okay, so I have been provided with axial contrast CT scan of the lower chest and abdomen of a 35-year-old male patient who has been presented with acute abdominal pain. I will just take a moment to go through the entire scan before commenting upon my findings. So I can see there is ascites. Uh, there is omental caking, I guess. I'm just okay. So I can see there is gross amount of ascites. The bowel loops appear not
Sorry,
norm.
yeah. Sorry, yeah, go ahead.
Okay, the bowel loops appear normal in caliber. Uh,
Mhm.
there is mesenteric paniculitis, and so I'll just go systematically.
Mhm.
The liver surface appear irregular. Um, the spleen appears unremarkable. I'm looking for the pancreas. Okay. The pancreas appears normal. Bilateral kidneys appear grossly normal. Uh, I would like to look at the pelvis. So this is a male patient. There is right inguinal hernia, but this is a mesenteric paniculitis with gross ascites, and uh, I would like to look at the coronal image sections if available.
Before you go on to the coronals, have you found a reason for any of these findings?
Mm,
Or if you need to tell me why you want the coronal, what do you need from the coronals?
mm. So first of all, I think there is liver parenchymal disease because
Okay.
the liver surface is irregular, and the there is ascites, but the spleen appear unremarkable, and there is mesenteric paniculitis. Uh, so
When you say mesenteric paniculitis, if you explain the word to me, what do you mean?
so there is like infiltration of the sorry, I was meaning the omental caking. Uh,
Can you show me the areas where you think there is omental caking?
here.
What does
Maybe
omental caking mean? What do you understand by the term?
infiltration of the omentum by like nodular densities. I think this
Okay,
can also be due to ascites. Uh,
right. So can you see any nodular densities that you were referring to?
um, no, not really.
So would you then like to change your description for the omental appearance?
Uh, yes, it appears edematous. I can see there are multiple diverticuli involving the transverse colon. I could not see any. Here I can see the bowel loops appear thickened with there is surrounding fat standing. Uh,
Which bowel loop?
the ascending colon and
Okay.
sigmoid colon. I am looking for the pancreas for the appendix. Mm, sorry, it is, uh, this I could not mm, like I want
When you report a CT abdomen in your normal practice, do you follow a checklist? What's your reporting style?
so I first of all I look at the all the viscera, then uh,
Okay, you've
the
already described all the viscera to me.
yes,
What next?
then bowel loops, like stomach,
Okay.
duodenum,
Have you
jejunum.
described, have you looked at all the bowel loops in this study to your satisfaction?
uh, the jejunal loops appear normal. There is
If you click on the screen, the blue screen should go away.
I'm clicking, sir, but it is not.
Give me. I'm just taking the control once. Yeah, go ahead. Yeah, you can go ahead. You can keep scrolling back now. Yeah. So you were saying, I think that the jejunal loops look okay.
Yes, sir. The stomach also appear normal. The duodenum
Mm-hmm.
is crossing the midline. Uh,
Mm-hmm.
oh, the jejunal loops are normal.
Mm-hmm. What about the ileum?
Uh, so, so it is skipping. The ileal loops appear diffusely thick, ileal loops show diffuse wall thick.
Uh,
I
there was
think
this. I think that was the timer. Yeah.
timer for 5 minutes. Yeah.
Should we let him finish and take time from the next case or move to the next case?
I think we can give him a 1 or 2 minutes more, and then we can
Okay.
move to the next case.
So you were saying that the ileal loops. You were describing the ileal loops for me. Go ahead.
Just a second.
I think it is easier if you use a scroll wheel, so it stops going blue, but it does. I know it interferes with your speed. Sorry.
Uh, there is thickening of the cecum, and there are a few air foci noted surrounding the cecum. Uh, I am just confirming them once again.
You moved on to the cecum. Did you finish describing the ileum for me? You said it's the wall appears thickened. Anything else strikes you
Uh,
as
the
uh,
the
abnormal about the ileum?
the the mesenteric vessels appear prominent. The vasa recta appear prominent, and
If you let me have control back, I have a specific question. So if I stop in this loop here, this is the ileal loop you were describing. Can you try and describe this for me once again?
the ileal loop is appearing. It shows diffuse wall thickening, and
Mm-hmm.
the enhancement is
I'm sorry, you cut off. I couldn't hear you complete the sentence.
the enhancement is I guess normal, and
So if you had to summarize the case, what would you say based on what you have described till now?
mm,
And if you reached a conclusion, what would you suggest as the next step?
as a
You did ask for the coronal ones. I'm more than happy to show it to you now if you want to see it once. Although I personally do not think it adds anything of value here. Is there anything specific you were looking for when you asked for the coronals?
mm, I just wanted to look for
No problem. Don't worry about it. So we'll move on to the second case. Okay. Just
yes.
a moment. So this is a patient who presented with a 34-year-old man presented with sudden onset lower limb weakness.
So this is axial MRI uh, T T2 weighted images of a patient who presented with a sudden onset of weakness. Um I will just scroll through the whole stack of images first before commenting upon my findings. Okay, so I can see there are abnormal intensity involving the spinal cord. So so I won't be able to do it.
So I couldn't hear you. So you were describing the spinal cord, right?
Yes, sir. There is abnormal T2 hyperintensity involving the spinal.
Yes.
Uh,
Okay.
uh,
In your normal practice, which sequences do you usually use?
uh, I would like I would like to look at um, the stir images.
The start images, okay. So I can provide you if you let go of the mouse for a moment, I can provide you the sagittal stir. Here you go.
So I've been provided with sagittal stir images. Uh, uh, I can see there is increase in signal intensity
Yes.
involving the lower spinal cord. Uh,
Mm-hmm.
uh, um,
So you've already looked at them on the axial and the sagittal. What are your differentials?
So this can be like syringomalia, syrinx. Also, it can be if it would have been in the anterior part, it could be spinal cord infarct.
If
Uh,
you go back to the axial, if you let go of the mouse, I will go take you to the back to the axial. So describe which part of the cord do you think this is?
it is central part.
Okay, so what did you just say?
Uh, if it would have been in anterior part.
Okay, so do you think this fits the picture?
Sorry, sir.
No, so do you think that fits this,
No,
given the clinical information and the finding, do you think this is compatible with the diagnosis that you have?
no, sir.
Is there any other sequence that might help you decide?
Mm, post contrast images are
I don't have post contrast, but I do have uh, axial ADC. So if you want to scroll, they're not particularly helpful, I know.
yes, sir.
So, okay, so you've seen the high signal, you've seen that in axial and sagittal, and based on the clinical information that you have been provided, what are your differentials?
Uh, it is sudden onset weakness, so
Yes.
it could be like transverse myelitis. Uh,
Mm-hmm.
it could be
Didn't you just say it could be cord infarct?
yes, I earlier said that. Uh,
Okay, so two differentials, and which one would you choose if you had to choose between any one? Which one would you favor?
Mm, it is acute presentation, so
Mm-hmm.
can be infarction.
Okay. And what are the causes of infarction that you know of in a cord?
Anterior spinal artery blockage.
Okay. What typically causes that?
Post um, interventional procedure like
This patient did not have any recent interventions.
any thromboembolism.
Okay, so if you suspect that, what is your next step?
I would like to get an CT angiography and
Uh,
the
okay, I don't have an angiogram, but I think I have the next best thing. If you let go, so this is the CT sagittal of the same patient.
okay. So I've been provided with the sagittal CT of this patient. So I can see there is a intimal flap involving the uh, descending thoracic and abdominal aorta. It is arising distal to the left subclavian artery. So this is Stanford type B dissection uh, of the aortic dissection. And this is an emergency. So I would immediately inform the vascular team about this, refer this patient to vascular team for. Uh, but I would like to look if it is not extending on these limited sequences to the like ascending aorta. So the management would comprise of conservative management, control of hypertension. But I would like to see in the axial abdomen scan if there are any organs or blood supply getting compromised. If it is, then we can. Then this patient would be urgently uh, managed.
Okay. Okay, so I will now give you your third case. Ready?
Yes.
Okay, here you go. Young woman presenting with headache.
So this is the axial T2 weighted MRI of a young woman who has presented with headache. I will just take a moment to look at the whole stack of images. So in my first scroll, I could not find any gross abnormality. Now I would look at my review areas. There is no evidence of dilatation of the ventricles. Uh, the brainstem looks normal. The basilar artery flow wide appears normal. Um, the posterior fossa appears normal. I would look at the sagittal, sorry, superior sagittal sinuses. The fluid appear intact. Um, I'm looking at the suprasellar. The cella appears partially empty, and I'm looking at the orbits. The the orbits appear unremarkable. So uh, I would like to uh, look at the uh, T1 weighted images, then diffusion weighted images, and
Okay, so if you let go of it, I will give you T1 first. You asked for it.
so then there is no any evidence of any hemorrhagic focus in. Mm, I can.
Is that your usual go-to sequence to look for hemorrhage,
I
the
will look at
T1?
no. I will look at it on the SWI images.
I
Uh,
don't have SWI, but if you let go of the mouse, I do have gradient echo here.
no, there is no evidence of any hemorrhage.
Are you sure?
I'm just Double checking. Yes, sir.
Okay.
So
You mentioned you want the DWI. Let me give that to you. Here you go.
there is no evidence of hyperintensity on the DWI.
Mhm.
Next, I would like to look at the like venography images if available, but on the
Why do you want the venography image?
I could not see any venous sinus thrombosis on the
Which is your preferred sequence to look for venous sinus thrombosis, or rather, which sequence or plane do you prefer when you want to evaluate the sinuses?
I will look at the flare and MR venography.
If you don't have on a standard MRI brain is what I'm talking about, because you raise the suspicion and then you order a venography. I'm assuming that's the usual practice everywhere, but you don't directly get a venography unless there are
Yes.
other factors that increase your pretest probability really high. So you said you use the flare. What do you expect to see in flare?
There will be flared hyperintensity involving the sinuses, but there are no any hyperintense signal. Uh, I can say there are prominent vessels involving the uh, scalp. Mm, I would look at the like internal carotid arteries and MCA.
What do you think these are? So we reviewed the GRE images before, and what do you think these are?
These are the cortical veins, which show
Do
thrombus.
they normally appear dark on GRE?
No, sir. They are appearing dark on GRE, so they look like they appear thrombosed.
Mm-hmm.
Uh,
So how would you like to summarize this report?
so um, there is cortical venous thrombosis, uh,
Mm-hmm.
and but there is no evidence of superior sagittal sinus thrombosis, and there is no evidence of any.
Okay, so you said you wanted a venogram. So let me try and give you the venogram. If you just let go of the mouse for a moment, sorry. This was, no, this is not the venogram.
In
Yeah,
this,
if you, that was just a CT, I think. Yeah, this was the CT if you want to take a look at it. But the next one is a venogram.
in this axial non-contrast CT, the superior sagittal sinus appear hyperdense.
Mm-hmm.
Um, Sorry. This- And there are hyperdense areas noted in the bilateral occipital regions. This
I
could,
think we're out of time. I think so. Okay, we'll stop here. Uh, and these are the three cases. So we'll do your feedback after we do the we do all the vivas. Is that okay?
yes, sir.
Okay. Who's the next candidate?
Uh, Candidate B, you can unmute yourself. Yeah.
Sir, I am the next candidate. Good evening, sir.
Okay. Hi. Are you ready?
Yes, sir. Sir,
Okay. Yeah.
regarding the request, sir.
Uh, about the control.
Yes, sir.
Yep. Approved. Okay.
Okay, sir.
Yes. All right. So the first patient is this one, and the history is this is a 34-year-old lady, chronic abdominal pain
Okay, sir.
for a long time. She's known to the hospital and has presented acutely. What do you think?
Sir, chronic abdominal pain and presented acutely to the hospital.
Yeah. Yeah. Known chronically and has presented acutely. Yes.
Okay, sir. Sir, so I have been presented with T2 fat set axial images. Uh, Let me scroll through the images before making a comment.
Mhm.
Sir, sir, I can see that there is a sir long segment thickening involving the ileal loops as well as the cecum and portion of the ascending colon. I can see that there is intermittent areas of normal bowel, which is showing normal bowel thickness that are suggestive of skip areas. I can see that there is mild surrounding pericecal and uh, periileal fat standing. I can also see that there are few tiny retroperitoneal lymph nodes around the area of fat standing. The liver looks grossly unremarkable and shows normal signal intensity. Spleen, pancreas are is appear normal. There is a small cortical cyst involving the right kidney. The rectum, I think, is loaded with fecal contents. The proximal duodenum as well as the jejunal loops, they show normal caliber and mural thickness. No definite free fluid seen. Sir, I would like to further assess the coronal images if available
Why?
to see. So to definitely look for IC junction involvement as well as to better correlate the anatomy, which includes the
Which
large.
coronal sequence would you prefer?
Sir, T2 coronal, sir.
T2 coronal. Okay. If you let go of the mouse for a moment,
Sure, sir.
I will give you here. Here you go.
Okay, sir. So these are the T2 coronal. Sir, the images are not dragging.
If you click once here, you should have control.
Yes, sir. So these are the T2 coronal images of the same patient. Here I can see that there is, as seen on the axial images, there is diffuse long segment thickening involving the ileal loops, and the IC junction is also involved with thickening of the cecum as well as the proximal part of the ascending colon with surrounding fat standing. There is no ascites, and the visualized portion of the large bowel, rest of the large bowel, it appears normal to me. So considering the, sir, I would, in my routine practice, I would also like to see the post-contrast even weighted images also to look for any abnormal enhancement within the bowel thickening.
Here you
But
go.
so these are the post-contrast T1 weighted fat set images of the same patient.
Mhm.
Here I can see that there is enhancing neural thickening involving the same regions
Mhm.
with long segment involvement. I cannot see any eccentric wall thickening, and the wall thickening, it appears to be uh, uh, smooth and circumferential in appearance. There are few rective lymph nodes also. I can see that there are few areas of narrowing also in intermittent ileal loops. Uh, Though I would also like to assess the areas on better on sir late delayed images also to see whether they have disappeared or they are still the same. But I am
So you're
suspecting they
worried
may be
between normal
though,
peristalsis and stricture formation. Is that what you're
yes,
trying
sir.
to say? Okay.
Yes, sir. They look to be stricture to me. But considering the long segment involvement of the bowel with associated pericecal as well as the perileal fat standing. So I am suspecting that this is a case of inflammatory bowel disease, likely Crohn's disease, with terminal ileal, IC junction and proximal large bowel involvement. So I would refer this patient. I would like to see any previous images of this patient and for comparison. And I would like to refer this patient to gastroenterology, MDT, for further evaluation. And this patient may need further further treatment regarding the IBD condition, which may include the lifestyle modification as well as the disease modifying therapy. And in this case, I would also like to look for any extraintestinal manifestations also, like orthopedic evaluation to rule out any features of sacroiliitis or any ocular involvement, since it can be there can be extraintestinal manifestations also. And this patient needs follow-up. And
You
biopsy can
mentioned
also be
that
done.
this.
Biopsy can also be done if he's presenting for the first time. And the differential diagnosis includes intestinal tuberculosis, as well as there is a remote possibility of any cecal mass, though it looks unlikely considering the long segment involvement.
You mentioned this patient needs discussion in the MDT. Why does this patient need discussion in the MDT?
Sir, because since this patient is chronic and he may be taking any previous medications, so or he may be experiencing some new findings also, as I need to correlate the images with the previous images if available. So there can be development of new findings. So to cope up with them and to rule out any other extra-intestinal manifestations, this patient needs
Okay.
MDT discussion.
Okay. That's done. We'll give you the next case. Okay, ready?
Okay, sir, sure.
So this patient is a young man, 22-year-old, presenting with pain in his ankle after
Okay,
he
sir.
fell down.
Okay, sir. So I have been, sir, one second.
Sorry. Yep, here you go.
I have been presented with the axial T2 weighted images of the ankle. I can see that there is normal articulation of the ankle bones on the axial aspect. I can see that the tendons, they are showing normal visualized lateral as well as the medial tendons. They show normal signal intensity. I assume that there is, I think, diffuse thickening of the subcutaneous tissue involving the ankle region, subcutaneous fat. It appears to be prominent. The talofibular articulation is intact. There appears to be mild thickening in the region of anterior talofibular ligament, and it appears to be irregular and thickened in appearance. Though in my routine practice, I would like to assess it on coronal as well as the axial star images if available.
So if you let me give you that, here you go. This is the coronal fat set images.
So these are the fat site images of the same patient. The axial images have been provided. I can see that there is irregularity and thickening in the region of anterior talofibular ligament with areas of inhomogeneous signal intensity. And I could not make out the medial attachment of the talofibular ligament. I can also see that there is surrounding fluid around the anterior to the talus, and I can also see that there is diffuse edema of the subcutaneous tissue at other places, both anteriorly as well as posteriorly, and on the lateral aspect. The rest of the posterior talofibular ligament, it shows normal signal, and the calcaneofibular ligament, it also shows normal signal intensity. The tendons, they appear to be normal. In my routine practice, I would also like to assess the images of the same patient in other sections like sagittal plane,
If
as
you
well
let
as
go of
the.
the mouse, I will give you sagittal fat set images. Go ahead.
So in the axial fat set images, I can see that there is a presence of fluid in the region of anterior to the talar dome. The bones, there is minimal edema in the region of uh, mid talus, though it appears to be marrow edema, most likely inflammatory. The sinus tarsi, it appears normal. The tendo-Achilles as well as the plantar fascia appears normal. And I can see that I can also see that there is a irregularity uh, involving the region of. I can see there is irregularity in the region of distal fibula. I am suspecting that it may be a sequelae of some injury or any previous trauma.
Which irregularity are you talking about?
This irregularity, but I would like to see it on T1 weighted images if available.
So I can give you coronal PD or coronal T2. Let's start with
Sure,
the
sir,
PD.
sure.
Here you go.
Sure, sir.
Yeah.
So I could not. I find that there is a T1 hypointensity involving the region of lateral malleolus of fibula. So I am suspecting it to be a fracture uh, with minimal displacement. So correlating all my findings, this looks to me a case of a bony injury involving the lateral malleolus of fibula with associated ligamental injury in the form of anterior talofibular ligament avulsion with associated subcutaneous edema. In my routine practice, I would refer this patient urgently to the orthopedic surgeon for management of the fracture and ligamentous injury. And this patient may need immobilization and follow-up imaging for his treatment. And he may also undergo, he may be advised CT of the ankle region for better evaluation of the treatment planning.
Why would they need CT?
Sir, because sir, for evaluation of bony structures and for to rule out any other associated small bony injuries, which may include a fracture, they can be better assessed on a CT ankle.
So you're saying there are MRI findings in an ankle that you can miss and you can see them on CT, for example. Can you give me an example?
Sir, MR is, I think, but as we know that MR is better suited for soft tissue evaluation, though fractures are better evaluated on CT, but for correlation of this patient to rule out any other small bony injury, he may be advised CT.
In this patient, do you think there is any other injury that a CT will show that this MRI did not?
No, sir, not really.
Then are you sure you want to advise CT?
No, sir, not really, sir.
Okay.
If
Okay, I think
if the doctor
sorry.
wants it, then we can do.
Okay. We will stop here. Nikhil, do you want me to discuss them now and go ahead, or do you want to do the Viva now?
Anything is fine if you want to finish
I
off.
think I want to discuss first, and then if that's okay with you.
Yeah, absolutely. Yeah, go ahead.
Okay. So we'll start with candidate 1. Are you still here? Candidate A. Is candidate A still here? Is he not here?
Yes, sir. Hello.
Okay, hi,
Yes,
hi.
sir. It was not allowed to unmute.
Okay, sorry. So with this, let me just open my feedback. Okay, first of all, I want you to be very careful with the terms you use. Try and be as general as possible at the beginning of your case and less specific. So you said omental caking. Now, when you say omental caking, that implies soft tissue infiltration, nodular thickening. But then when I asked you to show me, you revised your opinion and said it's probably mesenteric edema or omental edema. This is what it is, it's edema. So be very careful with words you say because they have implications. And if nothing else, the examiners will challenge you. And the best case scenario is they just challenge you and you change your opinion and that's it. But it actually can count against you as well because if you say omental caking, then they presume you are thinking about malignancy. Why else would you say omental caking? So be very careful about the terms you use. So this is just omental edema.
Yes.
Lots of ascites as you described. Parenchymal disease, yes. Some portal venous and periportal and perisplenic collateral formation as well. But the findings that would have made a difference in this case that you missed was the fact that this loop of Powell, and even after I challenged so when I ask you something specific, or not me specifically, when the examiner asks you anything specific, they probably either want you to exclude something very important or diagnose something big. Otherwise, they won't usually, no one will mislead you. So each question carries some weight. So when I said this loop, and you compared this with this, you said the enhancement was normal. It is definitely not normal. It is definitely hypo-enhancing compared to the other bowel loops. You see how well enhancing they are, and if this should the wall, this is the wall which is thickened. So the lumen is not that dilated, but it is definitely hypo-enhancing. And the reason for that hypo-enhancement, again, this have a list of review areas. And if you had said that I will review the vessels, I would have actually prompted you, and you could have seen the portal vein coming down, superior mesenteric vein, and you could have seen this thrombus that is partially occluding the superior mesenteric vein. Even if you don't see the thrombus, that is fine. If you raise the suspicion that there is even if you can't say established bowel ischemia, because I know there is no pneumatosis, there is no portal venous air, even if you say I'm worried about it, there is impending, or I think it is there, and then you sort of express your thoughts that I'm looking for other signs of bowel ischemia, I'm looking for pneumatosis, I'm looking for free intraperitoneal air, I'm looking for portal venous air. As long as you go in the right direction, you will receive help from the examiner because they're allowed to help you as long as you demonstrate that you are being very safe and you're thinking in the right direction. So this was a standard on-call emergency case where there is superior mesenteric vein thrombus with bowel ischemia. The differentials are obviously it can be arterial ischemia, it can be non-occlusive ischemia, and since there is no small bowel obstruction, so you rule out the other abdominal emergencies. But yeah, since it's time critical, you will be expected to inform the vascular team, tell them that there is a ongoing or impending bowel ischemia, and then the rest, you know how to deal with the rest. So this was the bowel case. Any question specifically about this case, or we'll move on? I think we've covered all the findings. And yeah, the other thing that I wanted to say was I will never interrupt. The examiner will never interrupt you. So when you are finished with your, let's say, saying something, conclude in a way that tells the examiner that he is done. So if you leave if you leave a gap between your sentences, the examiner never knows if you're still thinking or are you done with your description. So make sure you find a way to conclude your statements. Even if you're struggling, that's okay. But make sure there is a finality to how you end it so that they can then ask you a question, give you hints, or worst case scenario, move on to the next case. But make sure you don't let time slip by being indecisive about which way you want to go. Okay?
Yes.
And I think the biggest takeaway from this case for you should be have a list of absolutely critical emergencies that can come up in any in any exam. So abdominal CT, what are like the 10 things that you absolutely cannot miss? And make sure you tick them off in your brain before you think about other less likely possibilities. So under vascular, you absolutely must always look for arterial or venous or other kinds of vascular problems. Okay.
Yes.
This was this is where you started really well, and then you backtracked and you lost yourself in the in the discussion, or you lost yourself somewhere because you immediately noticed the finding. You said yes, axial. You said that there is cord signal abnormality, and you even remembered and correlated with the acute presentation, and you thought of cord infarct, but then you didn't quite clamp down on it. So this is very classic. I think there's a sign named after it, like owl's eye sign or
Owl.
eye of the owl sign or whatever you want to call it. But again, that's not important. The fact is bilateral, and I know it's not a very high quality image, but this is anterior cord. If it were posterior cord, you would get to see it sort of here. So anterior cord, bilateral, young man, acute. What your first differential is acute cord infarct, which you thought of, and then you went with transverse myelitis. Could present like this. I'm not saying it's impossible, but you usually see a slightly different pattern of involvement of the cord. It's more confluent. It's more present throughout the cord, or maybe eccentric, central. But it's not. It's never this characteristic two dots bilaterally. Here you can see it better here.
Yes.
And I offered you the ADC, but this, even if the ADC was normal, they should have given you a clue. Why does this patient have an ADC? This is not a routine sequence you run in a spine protocol. So sometimes you have to get clues from, if you're given them, you have to grab onto them. If there is an ADC, either cord infarct was they were considering it, even if you can't see it. So then that should have given you a hint, and you can go back and say what you think. And this is fine. You handled everything well here. You told exactly. You discussed the management. You appropriately flagged this as an emergency. Just don't forget that when you're describing the emergency, make sure that the patient also gets help for their cord. So I will recommend a neurology review for their cord infarct as well. So this is a two-part case. So make sure you don't forget the first part. Okay.
Yes.
And this was I know it's hard, but this is a fairly common way of them giving you something. So make sure you have a list of normal looking brain approach. And I remember when you were going through your T2 sequences, you said the venous sinuses look normal, but they were eventually found to be not normal. So be very careful and deliberate when you are saying something like this, that they are normal. You're completely allowed to say that I'm evaluating the venous sinuses. They look normal here, but in my routine practice, I would like to evaluate them on a coronal T2 or T1, whatever your usual practice is, or like SWI or your GRE. But make sure that when you say that something is normal, you have done your due diligence and you know for a fact that it is normal, because that counts against you. If you actively say that the pathology that is there is not there without looking at every sequence and every image, then that counts against you.
Yes.
But this is a common way of testing it. They start you with the unusual sequence. They might actually start you with here, and you just start saying, and then you're expected to see this, and then go back and try and work out where this is coming from. But yeah, this was a case of some dural thrombus as well as superior sagittal thrombus. You can see it here. This is the superior sagittal sinus thrombosis. And once you reach the diagnosis, you know how to manage it, flag it immediately, say, call the team, let them know. The rest is not really important. You can just as long as you flag it and tell them I've informed the clinical team. They don't always expect you to know about the details of the management. So you don't have to say, this patient will need, thrombophilia screen or dehydration, or are they pregnant? You don't need to waste time with that. That's their department. Okay.
Yes.
So these are the 3 cases that we discussed with you.
Thank you.
Okay, and candidate B.
Yes, sir.
You got the diagnosis right, but you missed an important factor is complications. So Crohn's, you described, don't bother with normal and expected descriptions. So fecal loading, liver, kidneys. If you know they're normal, just say rest of the solid organs appear normal. If you're confident, say it. You don't need to describe it, because you immediately notice that the pathology was in the bowel. So
Yes, sir.
spend your time saying what you want to say about the bowel. For instance, you spend time talking about possible stricture versus peristalsis. That's well done. They'll appreciate that. But in this particular patient, he actually had a enterocolic fistula. So when you see bowel loops right next to each other with loss of fat plane in between, even
Yes,
if
sir.
you can't demonstrate actual luminal continuation, you have to flag it. And I think it's actually slightly better seen on the contrast images. Was it? Let's see. Yeah, it's right next to each other. There's probably multiple colic fistulas, but even if you can't demonstrate it on the picture,
Yes.
in this exam, as long as you tell them that this is making me suspicious for a fistulation, and even in real practice, sometimes we can't see it, but we describe it exactly like that in our report. Bowel loops next to each other, lots of inflammation, possible communication, can't exclude an underlying enterocolic, enterocutaneous, enterovesical, any type of fistula. So they want to know that you know about these complications and you're actively looking for them. Okay.
Yes. Yes, sir.
And the other thing, and don't recommend MDT referral for everything. The MDTs are usually more of a, if you're not sure why this patient needs an MDT discussion, just say, I will recommend a referral to gastroenterology or gastroenterology review. So and then gastroenterology can always send the patient for MDT. So the way this works in the NHS is we want to keep the referrals and frictions and further imaging to a minimum. And I'm just saying further imaging now because in the next case it becomes relevant for you. But make sure that you don't recommend things that are strictly not needed, that counts against you, because a wastage of resources is something that is important from an NHS perspective. Okay, so just say this patient, and the other clue was I said this patient has chronic abdominal pain and is known to the hospital. So if they ever tell you that this patient is known to the hospital, it means right now they want you to investigate what the current cause of presentation is. They don't need to know that you know about management of Crohn's disease, because the patient is already known to the hospital. They're here because of an acute presentation. You describe acute complications and anything that might change management. Okay.
Okay, sir.
And remember to review previous images, which you did. Just but don't mix it up with MDT. So when I asked you why this patient needs MDT, you said because I need to review previous images. You need to review previous images for everyone. That is not the answer for why this patient needs MDT. Okay. That was this, and this was you dealt with it fairly well. MSK is you need to have bad luck to get MSK cases in your FRCR Viva. But if you do, just realize that it's going to be something very obvious. They're not going to give you a very unusual tumor or a tiny ligament injury that you have to look for half an hour. That's never what's going to happen. So for like in this case, I want you to be a bit more confident when you say this. This is a clear fracture. You saw the line, you called it irregularity, but it's transcortical. It's going from this cortex to this, and this is clearly a fracture. You noticed it in the end, but be more definitive. And you found the ATFL injury. It's pretty high grade, probably some fibers there, but
Yes, sir.
functionally pretty high grade.
So
The
thank
only
you.
finding you did not miss, again, this is not a pass-fail area at all. This is probably something they would want to know once you've already established that you're passing, is the patient also has a high ankle sprain or an anterior syndesmotic injury. A good way to confirm is if you look at the control, which is the posterior syndesmosis. This is the band-like
Yes.
appearance you want to see anteriorly as well. Clearly, there is a lot of soft tissue gunk here, probably slightly older injury, some chronicity, because there's not a lot of edema high up there, some edema, but not a lot. So slightly older injury. But you found the fracture, you send the patient to the orthopedic surgeon or call it fracture clinic or whatever. It's fine. Well done.
Okay, sir. Thank you, sir. Sir, should I have the 2 cases only, or should I present one more case?
Oh, I forgot you got. We can do one more. So are you ready? We'll just quickly do 5 more minutes. Yeah, ready?
Sure, sir. Sure.
Yeah, go ahead. So this is a child presenting with the parent have brought the child. It's a baby really, and they have a swelling on their head. Go ahead.
Okay, sir. So I have been presented with the CT brain images of a child. Sir, I can see that there is enlargement of anterior bilateral frontal sulcal spaces.
Mhm.
So there is a soft tissue lesion in the superficial scalp area on the posterior aspect. And I can see that there is widening in the region of left lambdoid suture, and the soft tissue is in the posterior aspect on the left side. Sir, in my routine practice, I would like to assess the sagittal as well as the corneal images also. Besides this, I can also see that there is mild hyperdensity noted in the sulcal spaces of anterior high parietal region on the left side. I'm in my routine practice, I would also like to see the bone window of this image, as I am suspicious of any cranial fracture, because I can see that there is some widening, and adjacent to it there is soft tissue in this posterior scalp. The ventricular system, it appears to be normal. There is no midline shift. There is no evidence of any edema within the brain. The posterior fossa, it appears unremarkable. I can see that there is a fracture in the bony fracture in the right parietal bone. Though in my routine practice, I would like to see it on the bone window. I cannot see any mass lesion on the plane in this patient. Sir, considering the imaging findings and the presentation of the patient, I am highly suspicious about a non-accidental injury in this child. So I would like to assess the bone window images. And in my routine practice, I would also like to go for the skeletal survey in this patient to rule out any further injuries. And since I am suspicious about this child, I would also like to take the proper history and the evaluation of this patient. And I would like to admit this patient under the hospital setting, and also would notify the authorities till further assessment is made. So my principal diagnosis would be a non-accidental injury, and my differential diagnosis would include a traumatic injury, though I'm not getting the history about that.
You mentioned your fractures. Did you find anything else in the brain?
Sir, I feel, sir, I can find, sir, that, sir, SHO, which I find because I think there are sulcal hypertensities in this region, in anterior frontal as well as the left parietal region.
Okay.
So these are, sir, most likely, sir, associated SH. And there
You mean
are
subarachnoid hemorrhage, right?
Yes, sir. Sir, and plus there are bilateral subdural, sir, prominence of the extra axial spaces. So
Mhm.
they can also be, sir, subdural hygromas, which can be or chronic STH due to any history of any previous injury, which this child may have suffered.
Okay, so you've mentioned what you want to do in terms of management and where you want to send it. You've done all that. Is there any other imaging you want to do apart from skeletal survey, which I've already talked about?
Sir, I would also like to go for, sir, MRI brain imaging of this patient.
Why?
Sir, because sir, sir, I want to see, sir, any, as I said, sir, there can be, sir, associated subdural hygromas, which may this child may have suffered. So they can be better appreciated, sir, on that.
This is an axial T2 MRI brain of the same patient.
So, sir, I would also like to see the, sir, axial images. Sir, I can see that there are bilateral, sir, concavo-convex, sir, collections in bilateral cerebral hemispheres involving the frontoparietal as well as the temporal regions. And seem to, sir, displace the adjacent, sir, pial vessels medially at some places. And I can also see that there is subcutaneous edema in the left. So the images are jumping in the posterior parietal region, as noted in the sir, CT images. So these look to be, sir, subdural, sir, hygromas to me.
Okay.
Chronic subdural hygromas to me.
Okay, we'll just have a quick discussion. So yeah, you're absolutely right. You just need some polishing up, but you've got the diagnosis right. I just wish you were a bit quicker in diagnosing the hemorrhage. So you
Yes.
mentioned the fracture quite early. I know it's quite challenging. So if you had the bone window, you would have definitely been more definitive about the fracture lines, but they often don't have the best sequences for you, but you're still expected to treat the case in a way you would, even if it's limited. So yeah, fracture lines, they are coinciding with instead of saying soft tissue, you can be a bit more definitive. These are extracranial hematomas or scalvedal hematomas, whatever you want to call them.
Yes.
And there are multiple of them. So, and yes, quite rightly found the enlargement. It can be benign. We have an entity called, I think, Bessie. Keep forgetting. I don't do
Yes, sir.
pediatrics a lot,
But
but in this case where you know there is history of suspected injuries, you cannot ignore it. Then this can be hygromas. But the fact that you should be a bit more definitive in calling the sulcal densities and subarachnoid. Don't use SH. They don't often know. They don't use these acronyms here. So call it subarachnoid hemorrhage. Okay.
okay, sir.
And the question, you always remember you have to earn the next sequence or the next modality or the next step. So when you say MRI brain, make sure that you have a list of things needed. So you can say I want for better characterization of the subdural hematomas, which you did. Also to look for contusions, to look for hypoxic ischemic encephalopathy changes. SWI will show me chronicity of blood products that I want to see, or if there are small parenchymal injuries like DAI or shearing injuries that are CT occult, MRI will be able to show all of these. But yeah, again, I'm just nitpicking at this point. Well done with this. You got the main diagnosis. The key term to use when you get any non-accidental injury is that safeguarding is the term that is widely used in the NHS. So just say that I will raise and in the NHS, the way these pediatric radiology works, suspected NAIs are always reported exclusively by pediatric radiologists. You can, if you see one of these, you can flag it, but you have to mention that I will discuss this and refer this with the pediatric radiologist in my department and inform the team, authorities, safeguarding team about possible NAI. And you don't unilaterally go and take the history. You don't unilaterally admit the patient. These are not technically under your purview. So you just flag it to the appropriate person, and then you set the wheels in motion, right? You just tell them that I will inform the safeguarding team about a possible NAI. I will discuss it with the pediatric radiologist. I will escalate it appropriately, and they will then bring other services which are needed. They will do a proper interview of the parents. They will do an assessment whether this is NAI or traumatic. You don't unilaterally say that. Whether or not you can say as part of the thing that this patient might need a skeletal survey to look for fractures at other sites. That is an entirely reasonable thing to say. So
Okay, sir.
well done with this.
Okay, thank you, sir. Thank you so much.
Okay. So Nikhil, I'll hand it over to you now.
Yeah. Hi. Thank you so much, Dave, and thank you, candidate A and B.
Thank you, sir.
Yep. So I think without further ado, we'll go to candidate C. I'll just request them to mute one sec. Right. Candidate C, are you there?
Yes, yeah.
Hi, candidate C.
Okay.
So
Correct.
we'll start with so just a quick run through. You'll be given 5 minutes. You will see the timer on the top of your screen. Just be mindful of the time when you start discussing the case. Okay.
Okay.
I just basically want you to describe the findings, give your interpretations, summarize the case, and what your management would be. That's all, right? Do not beat around the bush. Be very precise on your discussion points and then summarize the case. Okay. This applies to both candidates C and D, right? So I'll just share the screen. Right. Are you able to see the screen, candidate C?
Yes. Yes.
Yes. Okay. So your time starts. Yes. Okay.
I ask for request.
Right. Yeah. Just hold on. Do not. Let me just start the
Okay.
timer. Okay. You can. Yeah. You can start your case. You can click and scroll. Okay.
Yes.
This is
Okay.
a young female who presented with abdominal pain.
This is MRI axial images of a young female who presented with abdominal pain. It is T1 sequence. I'll go through the images first and describe the findings. Okay, this is the last cut. And okay, now I'm going back again to the cranially. So this T1 image, I can say there's a uterus is bulky with internal, I can see the fetus-like structures noted. And I can see the fetus skull limbs and also I can notice. And I'm going to the right adnexa. I can see them some cystic, high T1 signal area with internal low signal intensity, which could be in T1 could be a blood product. So I would like to see this in T2 images to further characterization if available.
So what are your thought process at this point?
I think this is a intrauterine pregnancy with
Okay.
a corpus luteus is possible.
Possible, right? So what do you basically interpret with the T1 high bright signal that you see on this lesion? If you were to suppose it's a corpus luteal cyst.
Because either it could be a fat containing lesion also possible.
Okay.
So I would like to see this.
What fat containing lesion are you thinking about?
In a young patient, I would consider dermoid cyst, mature cystic dermoid teratoma.
Okay. Any other differentials?
Fat containing exhalation. I cannot.
Right. So what other sequence can I provide you to confirm your diagnosis or to help you further narrow it down?
First, I would like to see the fat sat images to see whether it is truly fat or not.
Sure. Can you leave the cursor?
Yeah, okay.
Yeah, go ahead.
So this lesion show peripheral high signal is suppressed in this fat sat images. So there's a fatty compound is there, but central area is also show fat sat with the rim of non-fat component. So this could be a fatty lesion in the right adnexa with the intrauterine pregnancy, I would consider as a mature cystic teratoma in a young patient. And if the patient is in acute abdominal pain, I also suspect it could be even a possible torsion because they are prone to get torsion. So I would like to review looking at the any torted pedicle, but I can't appreciate it, this image. If possible, I would like to see this in T2 images, if possible.
Right. Okay. You can leave your cursor.
Okay. This is T2 axial image, so it further confirms.
You can click and scroll. Yeah.
Yeah. Okay. Further confirms as an intrauterine pregnancy, and I also would like to see any intrauterine abnormality in placental abnormality. I cannot see any abnormal signatures in placenta. And also I'm looking at the fetus, any fetal abnormality. I cannot appreciate obvious abnormality in the fetus. Now I'm coming back to the right adnexa. It has the internal lesion shows low T2 rim sign. It could be a calcification. So I suspect this could be a, I think it's a dermoid. I'm looking for the pedicle. I cannot appreciate, I think some possibly a torted pedicle is here. So I think this could be a acute torsion of the non-teratoma. So I will, this urgent finding, I will inform this finding agent to the referring physician and for the gynecology review for the management. And if available, I will also review any prior images because this teratoma could be there previously also.
Are you done?
Yeah, thank you. Yes.
Okay. So what features favors dermoid cyst on ultrasound?
Dermoid cyst, I would like to see could be a dot and dash some sign like sign and also Rokitansky nodule also would be there. And then
What is
also sometimes
what
I
is
can
tip
see
of
some
what is
tooth-like
tip of
appearance.
sorry to interrupt you. What is tip of iceberg sign?
Tip of the iceberg is where a nodule is seen, the Rokitansky nodule is seen, with is like protruding into the within the lumen with underlying fluid material or something like that, I think.
But why is it called tip of the iceberg?
Because we can see the entire lesion within under the whole set of the lesion.
So before I did an MRI for this patient. So assuming for a fact this patient would have gone through ultrasound, right? And let's say on ultrasound, like you said, there was no signs of torsion. Would you be completely excluding a possibility of torsion if the ultrasound was normal?
No, because clinical is important because sometimes vascularity cannot be completely ruled out. Because
And can you give me another reason why torsion patient preserve the flow can be still preserved even if there is a torsion? Why? From an anatomical perspective.
Because torsion has dual multiple supply.
Right.
So
what are the two supplies that you're thinking about?
Ovarian artery and also come from the I think uterine artery branches also possible give rise to ovarian supply.
So why do you think torsion is very commonly seen in pregnancy? Do you agree that torsion happens very commonly in pregnant ladies?
Yes, I think so because torsion, because usually if it is a prior lesion, it is more prone to get torsion because of weighting, because of the weight of the lesion or nodule is more prone to get twisted around the pedicle. And also there's a mass-like area within the uterus also, it pushes the mass to the side. So it is because of external mass effect also that the ovaries can be torted.
So if not for dermoid cyst, what other possibilities could you consider in a pregnancy for a caution for torsion? Like if you see a lesion like this and there is, you say, torsion, what else can you think of apart from dermoid?
Other possibility could be a theca luteal cyst.
You already mentioned a possibility.
Corpus luteal cyst also there.
Right. So could you roughly give me a possibility of in what gestational age group will you see a torsion of ovaries in pregnancy if it were to be a corpus luteal cyst? Or in other words, to reframe your question, which is the gestational age where corpus luteal cyst will be largest?
It's up to the first trimester, because after beyond, I think it's beyond 13 or 14 weeks, corpus luteal cyst works won't be helpful, because after that corpus luteal will be regress. So I think in the first trimester is where will be the mostly corpus luteal cysts we'll see.
Okay, if I were to
Yeah.
argue that this could be an endometrioma, how would you substantiate endometrioma versus dermoid? Do you think it will be T1 bright in endometrioma as well?
Yeah, T1 will be bright, but T2 should be, there should be shading, and there should
Right.
be T2 hypo, the T2 dark spot should be there.
What about fat suppress sequence?
Fat set should not suppress because it's a blood product.
So in dermoid, what parameter in MRI are you using, or what physics behind MRI are you using to diagnose dermoid?
I think it's chemical shift, not chemical shift, fat set.
Okay, yeah, it's chemical shift artifact.
Okay.
Right, let's go to a second case. This is a young infant who presented with enlarging swelling of the thigh.
This is X-ray radiograph of left limb, including femur and the lower leg of young child presented with swelling of the limb. I can see there's a diffuse soft tissue swelling is noted involving the thigh and the lower leg. I cannot see an obvious calcification or any differential density within it. And I'm looking at the bones. The bones, the femur and the fibula also appear some diffuse sclerosed compared to the rest of the imaged spine or carpal bones or tarsal bones. And so in my routine practice, I will review any other orthogonal images if available. Otherwise, I can't find any obvious fractures. And in the spine also, I cannot appreciate any obvious abnormality. So in this point, I consider as it could be a soft tissue or diffuse soft tissue swelling in this young child. I would consider could be any vascular malformation or vascular malformation involved in the limb, or other could be hemihypertrophy, could be a syndromic patient also I would consider in this child. So I will review any prior images or any. I would like to know any about the contralateral limb. If it is normal size, so it could be a even hemihypertrophy if it is enlarged limb. So I will review any other images and also assess the orthogonal view of this image. Thank you.
So what are your differentials at this point when you see something like this?
So this could be a vascular malformation, soft tissue vascular malformation, such as lymphatic. Also other possibilities could be a lymphatic malformation, and also could be a limb hypertrophy. Could be like syndromic hypertrophy. Could be due to Beckwith-Whiteman syndrome or Klippel-Turnovi syndrome, like that.
Right. So what would you like to do next?
So I would like to if available, I would like to proceed with the ultrasound of the limb or would be for the MRI of the limbs.
Why not ultrasound? Why would you not prefer ultrasound over MRI as a first modality when you see something like this on an X-ray?
No, I would like to go for ultrasound first. Sorry.
What are you trying to look for in ultrasound?
Ultrasound, I can see because it's child, so I can see I can assess the soft tissue directly. So see vascular vessels, vascular structures.
So you told me you're thinking about vascular lesions. So what are the different categories or classifications of vascular lesions that you can?
It could be a arteriovenous malformation or venous malformation or lymphatic malformation.
So what are the clinching diagnostic factors that you see on ultrasound that can help you favor in either directions?
So if there's a flow if I can see the high flow, it's dependent on the flow. If it's a high flow, it could be arteriovenous malformation. Right. If there's any flow like a venous flow only, it could be a venous malformation. If I cannot see any vascular at all, it could be a lymphatic malformation either also.
So if I tell you that this lesion is venous, retrospectively on an X-ray, what specifically would you look for if it's a long-standing venous malformation?
I will look for phleboliths, but in this image, I already said I can't find any obvious calcification
Right.
of
So,
phleboliths, but in my routine practice, I would like to zoom and see.
right. Okay. So let's go with the MRI. This is the T1 weighted sequence. You can click and scroll.
I'll go through the first image, then I'll describe the findings. So this is the T1 axial images of the given patient. I'll go through the images first and describe the findings. Okay, this is the last image. And I can see the patient has diffuse swelling is predominantly in the subcutaneous tissue plane. And also muscles did not, I can see the muscles separately, which is not so enlarged compared to the subcutaneous fat. However, I would like to review this in other T2 images also. And I can see the flow vessel-like structure in the medial aspect of the limb. And I'm going to trace that where it is going. I cannot it's mostly travels through the subcutaneous tissue plane, and it's connecting to the femoral, I think it's femoral vessel here, and it shows normal flow of voids, and I cannot appreciate any other vascular structures within it. So, so this in this point, I consider this as still I keep as a vascular malformation as my first diagnosis. As a part of my diagnosis, I would like to proceed.
Hospital. If you have an appointment
So,
letter, you might find it easier to use the direct number on it. Otherwise, please select one of the following options.
Yeah.
If you are calling about an outpatient appointment or
I
procedure,
think
press
it's
1.
Dr. Dev's
If you are calling about an
mic.
operation, press 2. If you are calling about an X-ray
Just
or
a moment. Yeah. Okay, great. So, tell me about the extent of the lesion. What, in which plane is the lesion in?
It's this is T1, so I think this mostly in the subcutaneous tissue plane.
Okay. So
And
how can I help you finalize, I mean, to conclude more into defining the plane of the lesion?
I would like to see this in T2 images.
Okay. Here you go.
So this is T2 axial images. Yeah, I can see the lesion predominantly superficial to the fatty layer, muscular layer, and this
is T2. This is T2 fat sat for your kind information.
Yeah, yeah. So this is mainly involved in subcutaneous tissue plane, not into the muscle plane, and I can see some high signal intensity within the subcutaneous tissue plane, even though it is fat set. So it's likely due to the soft tissue edema associated within it, and as also I can see the flow weights as I mentioned previously. So this could be a. I would like to see the post contrast images if available.
Here you have the post contrast images.
So in this post contrast image, I am looking confirmed down. So the vessels show contrast enhancement, but I cannot appreciate any other significant vascular structures within the enlarged subcutaneous tissue, so swelling. So this is as I think of a vascular malformation with probably a venous malformation. So I will review this. I will convey the findings to the referring physician, arrange for the pediatric vascular team for the further management and MDM discussion.
Okay. Can this be an hemangioma? Can this be an infantile hemangioma? If yes, why? If no, why?
Infantile hemangioma should be T2 high signal should be there diffusely,
Okay.
and it should also show vascular enhancement, and it should also show progressive contrast enhancement should be there, which I cannot see here.
Okay.
And
What about the infiltrative pattern of this lesion?
this is it's very, I can't appreciate definite. It's like ill-defined, diffusely infiltrate the entire
Do you
limb.
want me? Do you want me to show you a stir sequence?
Sorry, I can't get. Yeah.
Stir sequence. You can go
Okay.
through it. Yeah.
So this is a stir sequence of the patient's coronal images. I can see both limbs compared to the contralateral limbs. The diffuse subcutaneous soft tissues show high signal intensity, and also I can see the bones also appear enlarged compared to the right side, left side bones also. It's I think due to the increased vascularity, it can cause bone overgrowth. And
Any additional
I can't-
information? Any additional information that you want to add, which you have not
think-
added so far?
Here I can see some high signal intensity within the muscular
Muscles?
plane.
Okay.
That
So,
also
so what are your differentials at this point? Now that you know the extent of the lesion and you know the signal changes, what are your assumptions at this point? You said vascular lesion as a possibility, I agree.
yes.
And what are the possibilities apart from vascular lesions?
Lymphatic malformation is less likely because I can't see any fluid levels of cystic areas. And other possibility could be any hypertrophy, could be any other. I think this
Malignancies? Any malignancies that you can think about?
could be possible rhabdomyosarcoma, but
Okay, what would you like to do next?
so I would like to convey this finding to a referring physician and arrange pediatric surgical MDM for the further management. And also, if there's a possible malignancy, I would also do the staging CT chest abdomen pelvis also for the further management.
Last question. If I were to tell you that this patient has low platelet and consumptive coagulopathy with this lesion, does it ring a bell about any possible diagnosis?
Then it could be hemangioma, because hemangioma can cause a consumptive coagulopathy.
Any specific diagnosis that you can think of? Not exactly hemangioma. This is not relevant to the case because, but then still, this is something which I wanted to think about. If this patient has consumptive coagulopathy, do you know the name of the phenomenon associated with it?
Kassalba-Merit
Merit
syndrome.
Right.
Yes.
So what lesion can you think about in infants when you have such a Casabat-Merit syndrome manifestations?
So it could be, I have seen a hepatic infantile hepatic hemangioma also can cause like that, large hemangiomas in
Right.
liver.
Okay. This is your third case. You can click and scroll. This patient is presenting with headache.
This is an uncontrasted axial image of a patient present with headache. I'll go through the images first and describe the findings. So I can't appreciate obvious abnormality, so I'm going through systematically. And here I cannot see any obvious hemorrhage, intracranial hemorrhages, no midline shift. Ventricles also appear normal size lateral ventricles. I think I can see some added soft tissue density, added density noted in the sphenoid bone, possibly plane of sphenoid region, is just abutting the basilar tip, but yes, that's my region of interest. And also I am going downwards. There's no tonsillar herniation, no any other abnormality I can't appreciate. So this added soft tissue density in the posterior to the posterior aspect of the sphenoid bone. So for further characterization, I would like to review any other plane image available, like such as sagittal images if available.
I can give you bone window.
Okay. Okay. So this is bone window images, axial. I'm looking for any bony destruction. I'm going through I'm also would like to see the rest of the image in bone window. I cannot appreciate any other. Here I can see some cortical erosion also is noted in the clivus region. So
what are your
it is
differentials at this point? What are your differentials at this point?
So as an adult patient, the midline with the clivus erosion and with the soft tissue density lesion in this age, I would suspect as my differential, I would go for either chordoma and also could be keep also metastasis if there's a non-primary. The possibility could be a osteomyelitis also. I will keep in this differential. For further evaluation, I would like to proceed with the MRI brain with post-contrast image.
So if you said about clival metastasis, what are the common primaries that can go to clivus?
It could be lungs and renal cells. Yes.
Right. Okay. So you said chordoma and clival mets. Why not chondrosarcoma?
Chondrosarcoma, usually I will see rings and axis calcification, but also it should likely off center rather than midline.
Okay. Okay. And so what would you like to do next?
I would like to proceed the MRI
Okay.
with the post contrast.
Which sequence do you want to see?
I would like to see the T2 because to see the high signal in the chordoma.
Right.
If it
Yeah,
is,
you can click and scroll. Yeah.
So this is T2 Excel images of the given patient. I have to go through the images first. I can't see any supratental abnormality. Here I can see the T2 bright signal is noted within the my region of interest in the clivus region is also abutting the right internal carotid artery, but its normal flow is noted, and it has also some prepontine cistern extension, but no significant mass effect on the pons and the basilar artery. Basilar artery also show normal flow void. Is there a possibility to look for? I would like to see this in sagittal images if available.
Unfortunately, we don't have sagittal images. Any other sequence that you wish to see to confirm your diagnosis?
I would like to see the T1 and the post-contrast images.
Okay. This is your T1.
So this is T1 MR. Brain shows slightly low and in high signal focal noted within it. And also I would like to proceed with the MR post-contrast.
Okay. This is your post-contrast.
So post-contrast shows heterogeneous enhancement. And I'm looking for any other focal lesion. The rest of the image I can't appreciate. So in this point, T2 bright signal with the post-contrast enhancement, I would keep as a T2 very bright, I would consider chordoma as my primary diagnosis. And also I would like to keep metastasis as a second my diagnosis if it is non-primary, non-primary. And I will convey these findings to the referring physician and arrange neurosurgical input and neurosurgical MDT for further management.
So if it were to be chordoma, mentioning about the clival location, is it relevant to say that it's involving upper 1/3, middle 1/3, or lower 1/3 of the clivus? Is it relevant from a surgical standpoint, or you can just mention it's a chordoma and then dispatch your report?
I'm not quite sure, but I think it might be relevant for the neurosurgical surgical management.
So tell me, if it's involving upper one-third, what clinical manifestations will the patient have?
It could involve the pituitary
Okay.
region also. It can erode the pituitary fossa and also
Okay.
cause pituitary dysfunction.
And if the patient has diplopia, which structure, anatomical structure should I be focused on from an imaging perspective?
Diplopia, then you should be able to look for the optic, the nerve supply to the orbits would be a
Optic, okay.
optic nerves.
Any other nerve with relevant to the structure that you're talking, like looking at the location?
And it should be a sixth nerve because
Sixth
it
nerve.
goes through the
What canal are we talking about?
Dorillo canal.
Dorillo canal, right? Okay. So I think we'll end with your three cases, and we'll get back to your feedback once we finish the last candidate. Thank you. Right. So I think we'll go to candidate D.
Yes.
Hi.
Good evening.
Good evening. So are you able to see my screen?
Yes.
Right. Okay. Right. Are you able to? Okay. Right. So this patient presented with occasional breathlessness and dyspnea. So you can start presenting your case.
Okay. This is the frontal chest radiograph of a skeletally mature patient. I can see there is reduced lung volumes in both the lungs, and there is also a large opacity projected over the left upper lung zone, which has some speculated margins as well. There are multiple small nodular opacities are also projected over the left upper and mid lung zone. And there are diffuse reticulations are seen in the background. Apart from this, there is blunting of the bilateral costophrenic angles are noted. I'm looking at the skeleton for any associated aggressive bony lesions. Okay. No evidence of any aggressive bony lesions I can appreciate. So in summary, there is a background of interstitial lung pattern, probably the interstitial lung disease with mass in the left upper lung zone, which is suspicious for the primary lung malignancy with associated pulmonary metastasis as well. So I would compare with previous any imaging available and also ask for the any occupational and drug history for the interstitial lung pattern and escalate this finding to the referring physician and further suggest CT thorax with contrast to look for the mass to further characterize the mass lesion as well as the background lung pattern.
Which drug are you thinking about when you see such a pattern in lung disease?
Amiodarone,
Okay.
cardiomyopathy.
Okay. Any chemotherapy drugs?
Yeah, bleomycin, busulfan.
Okay. Okay. And what about, why did you speak about occupational disease?
Asbestosis and silicosis can also cause the interstitial lung pattern. However, I cannot appreciate any calcified pleural plaques or any calcified mediastinal lymphadenopathy in this patient.
Are you sure?
Yes, there is subtle calcified plaques in along the left hemidiaphragm I can see. Apart from this, the bilateral hilum are slightly bulky. However, eggshell calcifications are not well visualized. I would confirm on the CT images.
Okay. So at this point of time, what do you think about this opacity that you're seeing in the left upper lobe?
It would be a primary lung malignancy.
Okay. And what about the calcifications that you saw in the left hemidiaphragm?
This could be a calcified pleural plaque, which could represent the previous any asbestos exposure.
Okay. Any other differentials for calcified pleural plaques?
It could be secondary to the hemothorax or any previous empyema.
So any other relevant history that you should be asking since you spoke about hemothorax?
I would ask for any previous history of trauma, but
Okay. If I tell you that this patient was admitted to the hospital in the intensive care for a couple of weeks with fever and chest pain, and then you see this calcification, what should you be thinking about?
then empyema.
Okay.
I would think about
And
the empyema with resultant fibrothorax.
And if I tell you that this patient had a recent travel to the endemic countries, what should you be thinking about?
Then histoplasmosis can be a possibility, also a tubercular calcified plaques.
What would you like to do next?
Next, I would do the CT thorax with contrast.
Okay, so which sequence do you want? Do you want to see the lung window or the mediastinal window?
First, I will go through the lung window images.
Okay, you can click and scroll.
Yes. Okay, these are the lung window images, axial sections. I would quickly scroll through the images first. Okay, I can appreciate there is a well-defined opacities, density lesion seen involving the left upper lobe, which is causing the bronchial cutoff. No evidence of any adjacent lung collapse seen. There are multiple pulmonary nodules are seen adjacent to this lesion. Apart from this, I would scroll the entire set of images to look for any other abnormality. Okay, there is bilateral minimal pleural effusion seen, and also adjacent atelectatic changes. There are few subpleural nodules are seen bilaterally. No evidence of any hemothorax. Few emphysematous changes are seen in the apical zones of the bilateral lung parenchyma. Further, I would like to go through the mediastinal window images.
Okay, which sequence, axial or coronal?
Axial will be okay. Okay, these are the post-contrast. Okay, post-contrast CT images, mediastinal window. I can see there is filling defect seen involving the bilateral pulmonary arteries. Okay, predominantly involving the middle and the lower interlobar pulmonary arteries, suggesting pulmonary thromboembolism. However, no evidence of any saddle-shaped thrombosis in the main pulmonary artery or any involving the main branches of the pulmonary artery. Okay. The lesion is invading into the adjacent mediastinum. No evidence of any enlarged lymph nodes in the mediastinum.
So what are your differentials at this point? What's your primary diagnosis and what would you like to do next?
Primary diagnosis is primary lung malignancy with pulmonary thromboembolism. This is an vascular emergency. I would urgently pick my phone and call to the referring physician immediately. This patient needs urgent anticoagulation. And for the mass lesion, I would compare with previous imaging and further lung MDT discussion and biopsy, image guided biopsy for further treatment planning, as well as CT abdomen for staging.
What is the earliest manifestation of asbestos exposure that you can see in lungs?
Pleural effusion.
Okay. In what timeline would you see it from the starting of the exposure?
Usually 10 to 20 years.
So if you see something like a pleural effusion, what are the must differentiators that you should rule out? Or in other words, what are the malignancies that are often associated with asbestosis?
Okay, most common is the primary lung malignancy, and the second most is the mesothelioma.
Where do you see mesothelioma more commonly?
After the 40 to 50 years
No,
of
no, I mean, which part of the lungs?
Okay, diffuse pleural thickening.
If not pleura, what other structure?
Pericardium, peritoneum.
Okay. And apart from mesothelioma and bronchogenic CA, where else will asbestos is known to cause cancer?
Sorry, I'm not sure about that.
Okay. And so what would you like to do next? I mean, after you've said, apart from referring the patient to oncology MDT, anything else from the occupational standpoint?
Yes, I would ask for the occupational history to the patient and also inform the appropriate authority as there is an compensation for the occupational disease exposure.
Okay. So this is your next case. You can click and scroll. This patient presented with memory loss, and also this patient has different difficult movements, body movements.
Okay. These are the fusion PET-CT images.
You might see a bit of a delay in the images as you scroll, so I would recommend you go scroll slowly.
Okay.
Go down, go down, go down. Yeah, go slow.
Okay. These are the fusion PET-CT images of the brain of a patient who, with loss of memory as well as movement abnormalities.
Yeah.
Okay, I can see there is an bilateral symmetrical uptake seen involving the cortical areas of the bilateral frontoparieto-temporal region as well as occipital. This is the last cut.
Okay.
So I'm going caudal to cranial again. I would like to review the areas which are spared. Okay, the bilateral anterior temporal lobes appears to be spared.
Are you trying to say it is spared, or what would you use the right terminology when you're looking at a PET imaging?
Photopenic areas.
Okay. So what does that signify?
Okay.
Does that signify something from physiological standpoint?
Yes. A frontotemporal dementia can cause
No, I mean, what does these bright signals mean on a PET imaging?
bright signal means there is an increased uptake in these areas,
And what
which
does
is
increased uptake mean?
increased uptake in the brain means it is normal uptake.
Or metabolism in other way, right?
Yeah, metabolism.
Right. So now, what abnormality are you seeing in this?
There is photopenic area, reduced uptake in seen involving the anterior part of the temporal lobes.
Okay.
So I
Anywhere
would
else? Anywhere else?
and involving the bilateral cerebellar hemispheres.
Okay.
I think apart from this, basal ganglia is also spared.
Mm-hmm.
Thalami are involved.
Mm-hmm. So what are you thinking about?
Mm, So the patient had the history of movement abnormality. So I'm thinking in terms of any Parkinson disease or with the history of dementia, this could also be a Alzheimer's disease. I would further correlate with the MRI brain images if available.
Okay. Which sequence do you want to see?
The
It's
flare.
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 Okay. You can click and scroll.
These are the flare images of the MRI brain. No signal intensity change seen involving the mentioned areas. There is diffuse generalized cerebral atrophy is seen as well as cerebellar atrophy. There is increased uptake seen involving increased and altered signal intensity seen involving the bilateral thalami, predominantly along the adjacent to the parasagittal location. The rest basal ganglia does not show any altered signal intensity.
Any other sequence that you would like to see?
Yes, diffusion weighted images.
No, unfortunately, we don't have it. I can show you T2 weighted sequence.
Okay. These are the T2 weighted images.
Can you show me the deep structures?
Sorry, which structures?
The deep structures, I mean, the basal ganglia structures.
Yeah. Yeah, this is the basal ganglia involving the caudate nucleus.
Okay. Can you trace caudate nucleus for me? Can you trace caudate nucleus for me?
Yes.
The head,
This is,
body.
yes, this is the body of caudate nucleus,
Okay.
and this is the head of caudate nucleus,
Where exactly is the head?
adjacent to the frontal horns.
Okay.
This area. Okay.
Okay. You think it's normal?
I think it is hypointense on these T2 weighted images.
Okay.
It usually shows the hyperintensity.
Okay.
So
So
this could
connecting both the dots from PET imaging and these findings, what are your possibilities? And also clinical manifestations of the case.
yeah. So correlating these findings, so this could represent Parkinson disease as there is involvement of the caudate nucleus. Then I would also correlate with the previous any imaging available and the patient's clinical history, and refer to the case to the neurology team.
Right. Okay. This is your third case. This patient presented with abdominal pain and weight loss.
Okay. These are the MRI abdomen images, T2-weighted sequence, who presented with the weight loss. I would quickly scroll through the images first. Okay. I can see there is a transplanted kidney seen in the right iliac fossa. The bilateral native kidneys are atrophic in size. Okay. So in a transplanted kidney, I would look for the any abnormal bowel wall thickening. Okay. There are a few small bowel loops show circumferential bowel wall thickening in the left lumbar region, probably the jejunal loops. No evidence of any free fluid in the abdomen. No, I would look for the any associated lymphadenopathy. Okay, no enlarged lymph nodes are seen. The solid organs appear grossly normal apart from the bilateral kidneys. So I would like to review any coronal images to trace the bowel loops.
Okay. One sec. Can you leave the cursor?
Yeah.
Okay, here you go.
These are the coronal T2 weighted images, T2 fat sat stir images. Okay. The mentioned bowel loops seen shows the circumferential bowel wall thickening, no evidence of any stricture or any proximal dilatation. I would also, in my routine practice, I would trace the large bowel loops as well. But in this case, I am thinking in terms of post-transplant lymphoproliferative disorder with causing the small bowel circumferential thickening. I would compare with any previous imaging available.
What would you like to do next?
I would look at the post-contrast images if available.
Okay. And in the prior imaging, it was not there.
Okay. Then I would red flag this case and I would urgently communicate these findings to the referring physician and further suggest GIMDT referral for endoscopic biopsy of this bowel wall thickening and further staging CT chest and abdomen.
So what are your differentials? You said PTLD is one differential. What are your other differentials?
Other differential could be if the patient is immunocompromised, then this could represent a neutropenic colitis with
Where do you think neutropenic colitis comes often?
usually it comes in the ascending colon and the cecum region and then
Okay.
involving the small bowel loops.
Okay.
but in this patient, the ascending colon appears to be normal.
Okay. What are the other differentials?
Other differential could be then for bowel wall thickening, this could be a any inflammatory or infective thickening.
Okay. What infectious agents are you thinking about?
In the small bowel, mostly the giardiasis, cryptococcosis in the immunocompromised patient can cause the enteritis.
Okay.
Mm.
Any viral infections? Or in other words, what viral precursor should you be thinking about when you think of PTLD?
TLD. Not sure, sir.
Okay. How do you think CMV presents?
Yeah, cytomegalovirus. This could also give the bowel wall thickening.
So in what time duration should you expect CMV from post-transplant? What would be the timeline? Would you see it in first?
Usually within usually 1 to 3 months.
Sorry?
First to third months.
Okay. Are you sure?
I do not recall. I will
What are the other
uh,
associated
look
findings
at
that you would
the
see? What are the other associated findings that you would see with CMV apart from colitis?
colitis. I would also see any brain images for any evidence of any
In other words, what are the other CMV manifestations?
CMV manifestation in the abdomen or in the brain?
In the abdomen. In the abdomen.
In the abdomen. I'm not sure, sir.
Okay. Right. So, what from the management standpoint, what do you know? What is the next line of management to do when you're diagnosed with PTLD?
Yeah. Further, this patient needs an endoscopic biopsy of the wall thickening.
Okay.
And
No,
further,
I understand. You've diagnosed it as PTLD and everything is concluded. So you understand that in in transplant patients, your patient is on immunotherapy, right?
Yes.
And the immunotherapy has caused the PTLD, right?
Yes.
Right. So what would you do? Are you aware what
First,
the management is next?
yeah. First, we have to stop the immunosuppressants.
Right. So, but then that
Then
takes off the balance. That takes off the balance, and you're putting the patient more into risk of infections, right?
Yeah. Yeah.
Right. Okay. So in such cases, you bring in the transplant team into your discussion, into your MDT, and you need to create a balance where you treat the
Okay.
PTLD and also at the same time you're not completely taking away the immunosuppressants, right? So, do you know how often does this come back? I mean, how soon does it respond once the immunosuppressants are stopped? Or in other words, when should you be doing the next imaging once the treatment has started?
Uh, after the 1.5 months.
Okay. So, would you go with MRI or would you go with some other sequence, another modality?
MRI, as it will give the less radiation to the patient, as this requires lots of follow-up imaging.
Okay. So we'll conclude with your discussion on all the three cases here. We'll start with your feedback and then we'll go back to candidate C. Okay. So how do you think you presented across all the three cases?
I think that PET-CT image, it was not a good case. The first was okay, and this was also okay case.
You mean the good case, like I give the case was bad in terms, or you presented the
No,
case?
I presented.
Okay. So, okay, right. So this case was case of PTLD, right? And you were pretty good on picking it right on spot when you saw a graft kidney. And I think there, at that point, you scored very high on this case, right? And you were quickly to look at the bowel loops in the first instance, and you picked up the findings. So that is really commendable on this regard. Now, you oftentimes, apart from the bowel wall thickening, extranodal manifestations are very common with PTLD, right? And
Yes.
so it's just not that it only involves the bowel loops, right? It can involve the GIT. GIT is the most common site where it can come and involve, and also liver, spleen, etc. Right? So once PTLD is diagnosed, you should be aware that the next line is to inform the immunosuppression team, MDT team, to reduce the dose, completely suppress, nullify the immunosuppressant, because the response rate is really good. About 20 to 40 percentage patient resolves from PTLD, right? And then you need to create a balance on the
Okay.
treatment. You monitor with PET CT, and you could do a monitoring maybe in next 3 to 4 weeks. Okay, not an MRI. Ideally, PET CT would be good. Okay. And other differentials that you should be thinking about is CMV. CMV can cause adenopathy and hepatosplenomegaly, so always look for such associations. EBV is a very common association with PTLD, so remember about that as well. Another common things, I was expecting you to say lymphoma, but I don't know why you didn't say lymphoma when you saw a diffuse bowel wall thickening. So please mention a differential of lymphoma in this case when
Okay.
you see a differential, when you see a case like this. And of course, infectious causes, viral atypical organisms like mycobacterium TB is a close differential when you see a diffuse colitis like this. Okay. So
Yes.
I think you're a sure short pass on this case. You did pretty well on this, commendable. This case was a
Thank you.
case of Huntington's chorea. The reason I gave you a PET imaging to begin with was to show you that there is hypometabolism involving the caudate. You're not seeing any signal uptake in the caudate and also in the putamen, right? When in comparison to other areas, this is hypometabolic. With uh, bodily movements and cognitive decline, you should have thought about Huntington's chorea. And then when you come back to here, the caudate is literally absent. I mean, there is caudate atrophy in proportion compared to other structures, right? And putamen, not much, but yes, caudate is definitely atrophied in this case. So connecting the dots of caudate atrophy with hypometabolism and FDG PET, and you seeing clinical manifestations, think about Huntington's chorea, right? Do you know what are the two measurements that we take in Huntington's chorea?
No, sir.
Right. So you look at the distance between the two lateral ventricles. Is my cursor seen?
Yes.
Yeah. So you look at the distance between the inner table of the bone and also the intra distance between the ventricles. Okay. And also another measurement is you take the widest point from the caudate atrophy where you see maximum bulge into the lateral ventricle, and that, and also the distance between the frontal horns. Okay. Please go back to Radiopedia and you will see these measurements demonstrated beautifully. Okay. So please read about neurodegenerative diseases. PET imaging is very favorite among the FRCR exams. So, and also Alzheimer's and all these kind of neurodegenerative can come up in exams. So be prepared for that.
Okay.
This case was a case of asbestosis with lung malignancy. One small piece of advice, please look at the margins of the x-rays. Do not commit that you're not seeing anything abnormal. When the examiner tells you to look carefully, please be aware that you're missing something. Okay.
Yes.
And when you're looking at the CT, please make it a habit that the findings that you're seeing on the x-ray, make it a point to say that I confirm that these findings are present on the CT. That's a primary intention of doing a CT, right? You saw
Yes.
something on the X-ray, you're confirming it on CT. So the well-defined opacity that I saw in the left upper zone, I can confirm it that it appears hypodense on CT, right? With extension into the mediastinum, with no significant enhancement encasement of the vessels, suggestive of neoplastic etiology. And the calcification that I saw along the pleural margins are substantiating for the fact that these could be the ones that we saw on the X-ray. So the reason I was asking you, could this be empyema? Could this be hemothorax? You do not need the examiner to give you points on that. Okay. If I were you on in your place, I would have said that I see diffuse pleural calcifications in my routine practice. If this patient had a prior history of trauma, I would look for rib fractures, and this could possibly hint towards a hemothorax resolved into a calcified pleural plaque, right? And if this was a case of a patient who had traveled to endemic nation, I would think along the lines of tuberculosis. You see what I'm doing here, right?
Yes.
I'm trying to tell the examiner that I know these are the possibilities, and I also know what are the clinical histories that I should be looking for in the case, correct?
Mm.
So try to avoid making the examiner ask you questions. on the other hand, this is the place where you have to showcase your skills, right?
Yes. Yes.
Right. So I think otherwise you did this case pretty well. You're sure short pass on this as well. And I think, right, I think we have done with all the three cases on for you.
Yes. Thank you.
Right. Thank you so much. Candidate C, are you there?
Yes, I'm there.
Apologizing for all the, I think I might have given you a difficult, tougher side of the cases, but then I think it always prepares you for the best, right?
No, it's good for me. Thank you.
Right.
Thank you. Great cases.
Right. So this was case of torsion dermoid. And like you said, you were pretty good on your. Let me comment on the fact that your anatomical knowledge is pretty good. Your theory is pretty solid, and irrespective of how you present it across these three cases, you are a sure short pass for this exam. Okay, you have a great grip and composure, irrespective of what kind of cases are thrown at you, which is a important quality that you need when you're going in for an exam like this. Right. So in this case, this was a gravid uterus, and then you have a lesion, which is T1 hyper and T2 hyper, which is fat suppressed, which is classic dermoid, right? And you're seeing a hyperintense signal on T1 fat side, which is bleed. So Rokitansky is a possible factor that is coming into picture. So this was a case of dermoid, and you're seeing, like you said, there is looping of the vascular pedicle. So this was a torsion test, a torsion ovary with caused by a dermoid. The differentials that you should be thinking about is corpus luteal cyst, endometrioma, paraovarian cyst. Okay, do not be restricted to thinking, okay, this can be only corpus luteal cyst or dermoid. Please think, okay, it can be paraovarian cyst. I agree the imaging may not fit the picture, but there's no harm in giving a differential, right, for right head neck cell lesions. It can show at different varying stages of bleed. Still, it can manifest in any of these conditions, right? So otherwise, this was a solid case. You presented the case well. You picked up the findings well. So you're a sure short pass on this case. This was pretty tricky, I understand, and but again, you were very good with your differentials. I'm not really concerned about the diagnosis in this case. My only focus was to see how you approach the case, and you were smart enough to give me a differential of vascular malformation. Rhabdomyosarcoma, rare, but please do mention when you see an infant with an enlarging thigh mass. Are you there, candidate?
Yes, yes,
Yeah, right.
It's
So
gonna come to my mind.
yes. So, and also, stir sequence definitely gave you an evidence that it's involving the muscle. So there is a lesion which is infiltrative, which is transcending across the subcutaneous and the muscular planes, right? So it's an infiltrative lesion. Hemangioma generally doesn't cause such degree of infiltrations, right? So this was a case of a Kaposi form hemangioendothelioma. I'm not really concerned about the diagnosis in this case, but the fact that you had a logical analysis to your diagnosis, you gave very sensible diagnosis is commendable in this case, right? So when you see such cases, mention that you would go for ultrasound first, you would look at the vas, and same goes for the torsion case. You would like to go for an ultrasound and look at the vascularity, right? And then
Yes.
you would inform the physician and then go on with that. So this was so please think about malignancy also when you see a lesion like this. Yeah, so I think this case also you did pretty well. This was a case of clival chordoma. You were pretty good to pick up on the CT. And do you know why it's appearing bright on T1?
Not sure.
Mucoid
I
content,
can't
right?
recall.
The mucoid stroma. That is the reason
Okay.
for T1 bright. And I think there was a couple of questions that I asked. I forgot what were the questions that you were not able
You
to
asked
answer.
which level was the clivus, upper
Right,
level,
right.
mid level,
Exactly.
level,
So when it's in the
canal.
upper one third, so when you're reporting a clival tumor, please mention if it's upper one third, middle one third, lower one third. Upper one third pituitary symptoms like also in compressing the optic asthma, etc. And when you're coming down, you have symptoms. Middle at the middle one third, you have the Dorlos canal, abducens, diplopia, etc. So from a surgical standpoint, it's important for the surgeon to know, okay, this is something that I should be aware when I'm trying to remove the tumor, correct? And also the approach, the endoscopic approach is also relevant based on the upper, middle, and lower one third of the clivus, right? Differentials were good. Clival metastasis, chondrosarcoma also needs to be mentioned. Of course, it's seen off midline, but please do
Yeah, I
mention.
didn't see chondrosarcoma. I said osteomyelitis. Can you say
Osteomyelitis,
it
yes,
was?
osteomyelitis can be a possibility, but again, you would see other stir signal changes adjacent in the adjacent musculatures also, right? and you're not seeing anything of that sort. So if you've not said chondrosarcoma, do mention chondrosarcoma in the real exam. And of course, you can put it down and say that, though I would put it a little lower down because it's seen off midline, I would not be thinking much about it. Okay.
Yes, yeah.
Right. Okay. So I think both of you did pretty well on all the cases, and I have nothing more to add. If you have any doubts on all the cases that I've shown you, please, you're welcome to ask. Otherwise, all the very best. I think we have taken too much of time, all of your time, with this, but
Thank you, Dr. Nikhil. Great cases. And I have a question from Dr. Dev. I don't know if he is available or not.
let me see if he is around. Dr. Dev, are you there? I think
he's
I think
okay. No
he's not
problem.
available. Absolutely. Please feel free to connect in the group. I can always convey the message to him.
No, yesterday
Hello,
he
sir.
put me a case.
Yeah,
Hello?
yeah, please.
He put me a case cervical spondylolischitis, I think. Then
Oh,
I
right,
asked,
right, right. Yes,
I
yes.
asked for the MRI for post contrast, but he just
I'm not.
he asked that why was the contrast is it needed? I'm quite sure. I just want to know why there will
Absolutely.
be any contrast.
I think he was planning to show that case as well, but I don't know. He's not just available right now. I'm so sorry.
Okay, no problem.
I'll definitely tell
No
him to get
problem.
back to you. Yeah. So
Thank you, sir. Thank you so much, sir,
thank you,
for
thank you,
your
doctor.
cases, sir. It's
Thank
a
you.
really a privilege, sir. Big thanks.
Thank you so much. Thank you. So, all the candidates who have participated, thank you so much for being part with us, and all the observers too. We hope to see you again in the next session.
Thank you. Thank you.
Thank
Take
you so
care.
much. Yeah, bye, everybody.